Good morning, everyone. I thank KSOS and Dr. Geeta for the opportunity. In my presentation, I will be sharing our experience in setting up of a CVI clinic at Government Medical College, Thrissur, and the challenges we are facing. So our clinic started functioning about 3 years back. CVI clinic of Government Medical College, Thrissur is attached to the Regional Early Intervention Center and Autism Clinic, which works in the ground floor of the OP annex of our hospital. So we all know that REIC is a group of specialists, including the pediatrician and various therapists who work together to detect and treat children with developmental delay. So our clinic can adopt an interdisciplinary approach because we can provide all the services the child with developmental delay requires under the same roof. So this is the center is our clinic. The same corridor itself is the office of the pediatrician and various other therapists. So any child coming to the REIC will be first screened by a pediatrician who rules out any motor or sensory issue and will be sent to the CVI clinic. But a child coming straight to the CVI clinic after evaluation will always undergo a pediatric evaluation also. So our clinic is really very simple, functional. It's located, there's enough waiting area. Inside also there is enough space for the child to move around. Then there are instruments are kept in a clutter-free environment. Mats are provided for the child to lie down. And the lighting of the room also can be adjusted accordingly. So these are the various things. Everything is kept inside the cupboard. And we have all the almost all the instruments required for functional visual assessment, but everything is kept inside and taken out only when necessary. So I'm not going into the evaluation of the child because it was taken, it was discussed previously. But evaluation in our clinic starts with a meticulous history to suspect any perinatal insult. Then the child's parents has to fill in a inventory which will tell you about the visual behavior of the child. Then a detailed anterior segment, posterior segment and refraction will rule out the possible causes of ocular visual impairment. But what we are more interested in the visual behavior of the child also. How the child is brought into the room, what is he looking at, what's the color and the size of the object the child is interested in. Is they reaching out an object like that. So these are the aspects of the functional vision assessment we are testing. That is a visual acuity in young children with LIAP adults. Then contrast sensitivity by hiding HID and also visual fields. Then we also, in older children, we also employ LIA puzzle and LIA mailbox, which tests both the dorsal and the ventral stream. So another important function of our clinic is the intervention strategies in these children. So that is planned taking into account the medical history, observing how the child is functioning, then the visual assessment, functional visual assessment, and also whether the child is having any other disabilities. Our primary intervention strategy is early intervention. We have a trained optometrist who does weekly rounds in the high-risk NICU and pick up children who can later develop CVI and refer them to our clinic. And the intervention strategy is planned according to each child. It's a separate one. There's no uniform plan like that. And it is a teamwork between the therapist and the parents. And the parents should be clearly counseled about the nature of the visual defect, the need for further visits, lifelong support, and other therapies. So in a very young child, we may start vision stimulation activities. We offer office-based therapy sessions as well as supervised home exercises, and always a regular follow-up is encouraged. So we may start in a very young child with a illuminated toy in darkness, and then move on to another toy which or a card which can be used in the normal lighting. And it is always the mother's face which is the most favorite fixation target a child can have. So in some children we may be confused about whether the child is fixing or following. But using a illuminated toy in darkness and slowly moving will elicit the fixation and following clearly, and which can be followed up by other toys in daylight. And all then we also have lighthouse activities which promote the coordination, hand-eye, and so many activities can be planned in the light box. Then each activity is planned to improve one fish or support one visual function. It has some intention. All activities should be intentional. Then in this in older child with inferior field defect, the girl is encouraged to move down the stairs, and boy with optic ataxia who is given exercises which improve the hand-eye coordination. But the challenges we are facing are quite sometimes very discouraging. See, this child was with severe hypoxic ischemic encephalopathy, was picked up in our NICU. We had some vision intervention therapy sessions. Then child was lost for follow-up for 1 year. Then the parents brought this child recently with almost visually inattentive child because they had gone for some other therapies. Then there is still a lot of lack of awareness about this condition. This is a 4-year-old child from Lakshadweep. She was brought here she came to us only 6 months back. Then this 3-month-old child was referred to us by a nurse who had directed her because she was not looking at mother's face. We started vision therapy sessions and she was not improving. Then the optometrist noticed certain abnormal movements in the feet. Can you see that? And then pediatric evaluation and investigations revealed a rare genetic disease due to, that is, progressive encephalopathy and brain atrophy. And the child continued to regress in the future visits. This is also the case of an 8-month-old child who was brought with no visual awareness. Then it was detected that he had seizures and abnormal EEG findings, which was characteristic of the West syndrome, and he is not responding. Then it may be the coexisting disorders, which may be proved to be a challenge, like this central child with hypotonia, epileptic encephalopathy. It is so difficult to plan an intervention strategy. This child was brought with a developmental delay. We found that the child is quite visually active but not reaching out to objects. Then pediatric evaluation indicated that she had certain sorts of diplegia and cerebral palsy, and we had included more exercises to improve the hand-eye coordination. Then this 4-year-old child with spastic quadriplegia who barely opens his eyes and is so irritated if he does so is the ultimate challenge. But all children with CVI are not the same. We did not have much hope about this 72-day-old child with severe HIE and quadriparesia and so many other factors. But she showed surprisingly more visual activity, visual interest that is encouraging. So now I would like to share a few of the cases where we could make a significant difference. This 1-month-old boy with a diagnosis of hypoischemic encephalopathy was again picked up in our NICU. They started vision stimulation activities with patterned cards very early, and we were able to fixed activities started within 6 months. But the child had other challenges like seizures. But still, continuation of the therapies. Now, at 2 years, we have a very visually active child. Though the visual activity is very much improved, he has certain motor issues, which you can see the feet of the child, and it requires physiotherapy. Similar is a case of 1-year-old child with a diagnosis of HIV. She also was picked up very early, but the parents brought her only after 9 months of age. Then the child had no visual interest, not fixing or following light. We started vision stimulation activities, but was not responding. Then it was detected she has severe seizure disorders. I was admitted, treated in the pediatric department. But the mother is very young and she's very cooperative. She's very hardworking. So she brought the child for all the follow-ups and did all the exercises. So at 2 years, we have a visually active child. But now she looks so picture perfect at 2 years, but she has some speech issues and some behavioral problems which are being taken care of in the REIC. So this is the message I would like all of you to take home. Early identification of the disease, early intervention always gives you a better outcome. But any child detected at any time deserves a chance at the intervention activities. And the parental counseling and support is very important. Big thanks to our REIC team.
Thank you, Dr. Sujatha, for that wonderful presentation. She is doing a very good job in the government sector. It is not that very easy task to run a clinic in a government setup. And Dr. Geeta, our chief instructor, unfortunately, she couldn't come today. She is also doing a fantastic job in the government sector at Palakkad. For the last 5 to 6 years, she is running a very good CVI clinic. I think she is the first one to start a CVI clinic, especially in a government sector. A big round applause to them.